Good evening, everybody. Welcome to this faculty lecture in the Sagar teaching group on solitary nodule thyroid. Our HOD, Ravishankar, will be talking about it. As I keep saying, it's a very important topic, not only from the point of view of the exam, but also in clinical practice. And I'm sure you will hear a system-wise and a systematic algorithmic approach to what one should do when one encounters a solitary nodule of the thyroid. Over to you, Ravi.
Good evening. Thank you very much, sir, for the introduction. This is an approach to solitary nodule of the thyroid. So I will, go through, as sir said, a systematic approach to how you, manage, diagnose and manage a thyroid nodule, and we'll briefly touch upon the various, actors in this solitary nodule of the thyroid. So coming to the definition, it's a discrete lesion in the thyroid, clinically and radiologically distinct from the surrounding parenchyma. So this is the current and latest definition. Please understand, discrete lesion in the thyroid, clinically and radiologically distinct from the surrounding parenchyma. So these nodules are clinically palpable in about 1% of men and 5% in women. The incidence of this, if you look at even patients who undergo ultrasound and other investigative modalities and autopsies, it can range anywhere up to from 20 to 76%. So which is quite high. So almost 3/4 of all individuals can have a thyroid nodule. And obviously this the rate of detection or rate of incidence of these nodules increases with age. Coming to, if you look at all the nodules, benign nodules constitute about 85 to 90% of them, and malignant are about 10 to 15. When you have patients in whom you detect nodules above the age of 70 and less than age of 14, then you should be extremely cautious and suspicious. These nodules are more likely to be malignant than benign. So age more than 70 or less than 14. These are the two important ages that increases the risk of malignancy. And other thing, that there was a conception, common conception, that solitary nodules are more malignant than multinodular goiters, which across the board, looking at the lot of data, even from the SEER data from the United States and everywhere, it is now shown that solitary nodules have similar incidence of malignancy as are multinodular goiters. Now we'll come to the clinical evaluation. First, let us go into the history. See, radiation in childhood is an extremely important point that all postgraduates should concentrate on whenever they have a solitary nodule in the thyroid. Even small doses as 0.1 gray can increase the risk of malignancy, especially radiation in childhood. Other thing that we are increasingly seeing is that many children these days undergo dental x-rays, and these dental x-rays can increase the risk of radiation and consequently thyroid, and hence it is very advisable for children who undergo dental x-rays and the medical dental personnel who do these OPGs to cover their what we call as a thyroid shield to prevent the radiation to thyroid. The latency period between the radiation and onset of nodule, which could potentially turn into malignancy, can be 3 to 5 years, but it can keep on increasing up to the age of 40 years. It is as obviously primarily linked to a papillary carcinoma of the thyroid. And there is also family history of thyroid malignancy, though the exact risk is not yet known, though there are so many of these new genetic markers that are coming in, but there is no concrete evidence and proof that any of these are, though there is an increased risk, it has not yet been quantified and qualified. Other factor that could increase the risk of malignancy is increasing BMI will cause increasing risk of thyroid malignancies. Again, increased incidence of follicular carcinoma is seen. As you see, the radiation is associated with papillary carcinoma and iodine deficiency endemic areas. You see an increased risk of follicular carcinoma, but now with generous use of iodine supplementation in salt and other means across board all over the world, these the endemic areas are slowly decreasing and shrinking. Now, when you are taking the history of a solitary nodule, you should concentrate on the age of onset of the nodule. So when did the nodule appear in the thyroid as the patient noticed it, and what is the progression? Again, this is very important. Is there a slow progression, rapid, gradual progression, rapid progression, or sudden increase in size? So all of these points are extremely important. And then you also have to concentrate on symptoms of hyper and hypothyroidism, and also symptoms of pressure symptoms, which is hoarseness of voice, difficulty in breathing, and such like. Then coming to clinical evaluation, that is examination. I finished with the history, examination. Coming to features of hyper and hypothyroidism, so examine the patient for both, and then you also look for features suggestive of pressure or infiltration from the nodule. And this usually applies to larger nodules and nodules which are hard. Now you also have to examine the thyroid carefully to the size of the nodule, the number of nodules, and what is the status of the rest of the gland. And again, consistency, mobility of the thyroid or fixity thereof, and any palpable lymph nodes in the cervical region, and also possible signs of distant metastasis. So all of these features comprise of a clinical examination in the clinical evaluation of the thyroid nodule. So I'll stop here. Any questions so far from the postgraduates, or any addition to whatever I've said?
Sir, in the very first slide regarding clinical palpable 1% in men and 5% in women, sir, is it in the 1% of the known case of solitary nodule, or 1% of?
No, 1% of the population.
General
1% of general population and 5% of female population. So that is,
okay,
if you across the board.
Okay,
if
sir.
you just examine them, even if they have come for some other illness to the hospital, or some other sort of problem, let us say they have come for an umbilical hernia, you just do a perfunctory clinical examination. You will find, if you have examined 100 people, about one of them will have a thyroid nodule. This could be obviously in different areas, the incidence could be different, but on an average 1% in male and 5% in females will have palpable thyroid nodule.
Okay.
Or radiologically identified nodule.
Yes.
So if there are no other questions, I'll move forward. Now coming to the evaluation, radiological evaluation. So radiological evaluation is the not the first, but I would just briefly take a detour. I think as soon as you see a solitary nodule of the thyroid, it is mandatory that you get a TSH done. So this is the first investigation you have to do, and based on the TSH, then you plan your further investigations. So if your TSH is low, which means the patient is hyperthyroid, then the investigation of choice is a radionuclide scan. If the TSH is normal or high, then there is no point doing a radionuclide scan. I will come to that later, but the investigation obviously of choice will be ultrasound scan of the neck or the thyroid region. So the ultrasound scan is a high frequency 7.5 to 16 megahertz ultrasound scan. It is the primary mode of investigation. It apart from radiological examination, it also assists in focused FNAC, which is fine needle aspiration cytology, and it is also plays an important role in follow-up of patients on whom you have decided upon conservative treatment. The suspicious features in as far as an ultrasound scan is concerned is microcalcification, hypervascularity, infiltrative margins, hypoechoic nodule in relation to the rest of the gland, and taller than wider nodules. And obviously, it also picks up if there are lymph nodes in the region, it will also pick up the lymph nodes. So microcalcification, hypervascularity, infiltrative irregular margins, hypoechoic nodule, taller than wider nodules. Now, the American American Association of Radiologists has come up with similar to the BIRADS classification. They have come with the TIRADS classification. I didn't want to confuse you too much, but I will give you the TIRADS, ACR TIRADS classification. The TR1 is a benign nodule and TR2 is not suspicious nodule. TR3 is a mildly suspicious nodule. TR4 is moderately suspicious and TR5 is highly suspicious. You don't, as the sir said, you don't have to remember it. You know, it's obviously the job of the radiologist, but you should know there exists a similar system to BIRADS. There exists a TIRAD system, and as I said, the radiologists take into consideration the position of the nodule, the size of the nodule, shape of the nodule, margins, as I said, infiltrative irregular margins, content of the nodule, whether it is solid, cystic, mixed, and echogenicity, whether it is a hypoechoic nodule, and halo around the nodule, and vascularity, as I've already touched upon, and calcification. So all of these are given score. You don't have to remember the scores because I think the radiologists will remember it. So they will then, after they score it, they will go to this TIRADS 1 to 5. So this is a representative thing. So as you can see, here there is, microcalcification. In the second, picture, you can see irregular nodule and also, taller than the wider nodule. So all of these are features suggestive of it being a malignant nodule. So as I said, after, if the patient's TSH is low, only then you consider doing a radioisotope scan. So radioisotope scan can be either done by technetium 99M per technetate or iodine 123. Unfortunately, iodine 123 is not available in India. And so what they do is use a low dose I-131. So what are the indications? A nodule more than 1 centimeter with low TSH levels to identify a hot nodule. In patients, as I said, hypo and euthyroid patients, iodine or radioisotope scan is not indicated because it doesn't help the management. Even if it is a cold nodule or a warm nodule, it doesn't tell you whether it is malignant or benign. So though the reason why I say so is hot nodules are rarely malignant. I think the percentage, the highest figure I have seen is about 9%, but usually it is in the range of 2 to 3%. So, hot nodules are rarely malignant, so you don't have to worry. That is why when you have a patient whose TSH are low, which means the patient is hyperthyroid, you then do a radioisotope scan. Again, radioiodine scans are indicated in patients whom you suspect lingual thyroid or a substernal thyroid, which is entirely in the mediastinum. So what happens is when you do a CT scan or something to evaluate a mediastinal mass, it will only tell you that there is a anterior mediastinal mass. You may not be aware of what the nature of this is. In that case, if you are suspecting, and if the thyroid ultrasound scan of the thyroid region does not show any enlargement there, then if the suspicion is high, then you can go for a radioisotope scan, because the thyroid that is in the mediastinum will pick up the iodine or the technetium per technetate, and it will light up. So you will be then able to confirm that this is a mediastinal or a substernal goiter. And again, the use of radioisotope scan is in post-operative situations where you have, after you have done a thyroidectomy, you want to identify is there any residual disease or a metastatic disease. This is actually the best indication for radioisotope scan. So what you do, I will come to that later again when we do the post-operative situation. So I will explain that in detail there. Now the next investigation, I will put this as a combination CT scan or an MR scan. So large malignant goiters for evaluation of extrathyroidal disease and local infiltration, I think the CT scan will be useful. And nodal metastasis in the neck, I think CT scan scores over ultrasound scan as far as nodal metastasis is concerned. So if you want to be absolutely certain, you do a CT scan of the neck, which will tell you if there is any nodal metastasis or not. And then nodal metastasis in the mediastinum and mediastinal extension and evaluation of lung metastasis. So all these things, the CT scan and MR scan are useful for. Now coming to the fine needle aspiration cytology. So this again, you need to be extremely clear. Fine needle aspiration cytology, I will go as far as to say that FNAC has replaced frozen section as the diagnostic modality of choice in identifying this, the nature of the solitary nodule. So you use a 23 to 27 gauge needle, all nodules more than 1 centimeters, and suspicious nodules are to be evaluated. If, for example, if the nodule is clinically palpable and obvious, you could do an FNAC directly, or for you to be absolutely certain, you can use the help of an experienced ultrasonologist to guide you. The reason for this is you can, in the same nodule, you can actually target the most suspicious area so that you can increase your yield. So that is why you use the ultrasound guided. I think now that has become the standard of care. So ultrasound guided FNAC of the thyroid nodule is the standard. The sensitivity of such a test is about 86% and specificity is 91%. This can vary, of course, depending on how experienced your radiologist and how experienced your cytologist is, but that is the ballpark figure. There are 4 categories: malignant, indeterminate, benign, and non-diagnostic. So as I said, image guided FNAC in small suspicious and indeterminate nodules, now it has become probably standard. And as I said, why it has replaced frozen section in management. Now, can I just interrupt here and ask Pawan, why do you think I say that FNAC has replaced frozen section in management? Pawan?
Sir, am I audible?
Yeah. Not sure?
Not sure, sir.
Indraja?
Sir, FNAC in follicular carcinoma, it can't differentiate between adenoma or carcinoma.
Correct.
Yes.
Correct.
And we can also find out the grade of the tumor.
No, FNAC. No, FNAC, right. But I'm saying FNAC is the investigation of choice as far as the cytology is concerned, and better than frozen section. Why do I say that? Pooja?
Sir, less invasive, sir, and
Abdul?
Sir, in hyperthyroid patient, FNAC is much better compared
to. I'm not talking
frozen.
about hyperthyroid. I'm not talking about hyperthyroid. I'm talking about use of FNAC and frozen section in possible malignancy. See, it is like this. See, basically, FNAC will tell you whether it is papillary carcinoma or not most of the time. Okay, so as far as papillary carcinoma is concerned, you are quite happy. You probably know the diagnosis before. As far as follicular malignancies, even Hurtl cell is concerned, the FNAC will only tell you that it is a follicular neoplasm. Okay, so but then if you go for frozen section, even in frozen section, capsular and vascular invasion may not be obvious. So ultimately, you will end up with a very in a dilemma anyway. So FNAC will give you the necessary information that that is sufficient for you to plan your management anyway. So frozen section is not going to add anything more. If frozen section says that there is vascular invasion or capsular invasion, fine, but in about 20% of cases it can miss it. So in that case, then you are still wrong. So that is why frozen section is virtually going out of the diagnostic armamentarium. There are specialist centers where frozen sections is very well done. In those institutions, it may continue, but by and large, FNAC is sufficient, because medullary carcinoma, I will come to that again, medullary carcinoma and papillary carcinoma, almost certainly you will get the diagnosis before with the FNAC. Follicular, it will only tell you as a neoplasm. And then again, in lymphomas, it can still make a diagnosis. So in most of the thyroid malignancies, FNAC will give you the answer. I think the only doubt would be in follicular neoplasms, which even the frozen section may not be able to completely, differentiate. So as I told you, in papillary carcinoma, follicular cells with orphan Annie nucleus and Samoma bodies, that is a diagnostic, sort of sine qua non of papillary carcinoma. In medullary carcinoma, you see C-cell hyperplasia or dysplasia, and then immunohistochemistry, and in addition, calcitonin will tell you that this is a medullary carcinoma. As I said already, follicular and Hürthle cell CA is only labeled as adenomas. In lymphomas, with the use of flow cytometry and immunohistochemistry, almost always you will be able to diagnose, and most of the thyroid malignancies will be non-Hodgkin's lymphomas of B-cell origin or mucosa-associated lymphoid tissue or maltomas. Again, in anaplastic carcinomas, you'll see abnormal, irregular, poorly differentiated cells, which you will be able to say that this is a anaplastic carcinoma. So FNAC virtually answers most of your questions, and hence, I think that is the investigation modality of choice. I will just interrupt my talk here and ask Dr. Lakshman sir for his opinion.
I would agree with that. I would agree with that, because FNAC does not, frozen section does not definitively differentiate in all the cases. And so you're left with, if you're faced with an FNAC follicular neoplasm, left with two choices: either doing a total thyroidectomy, which may be an overkill, or give the choice of hemithyroidectomy with the possibility of another operation for completion thyroidectomy, and that usually happens in about 10 to 15% case of the cases at the most.
Yes, sir.
Yeah.
Yes, sir. Thank you. Anybody else? Anybody else?
Sir, FNAC, to give details about immunohistochemistry, is it reliable, sir? Like TrueCut they prefer, no, sir?
No, I think, basically the, TrueCut is preferred, but thyroid, nobody does the TrueCut. But, I think they will be able to, for example, in the smear that they get for lymphomas and for the FNAC, the flow cytometry and immunohistochemistry is only used for medullary carcinoma and lymphoma. I think they will be able to interpret it, because you'll see the cells, sheets of cells anyway.
Okay, sir.
Okay. So this is the papillary carcinoma, the FNAC. You can see the nice orphan Annie nucleus in that, and Samoma bodies. And the medullary carcinoma, the classical thing is the irregular cells of the parafollicular C-cell origin, and also the eosinophilic stroma. So that is the classical medullary carcinoma thyroid. And as you see, the anaplastic carcinoma here, irregular, large cells with abnormal nuclei, irregular shaped and large cells. And as you see, the lymphoma, classical, again, this you cannot, if you just put up this picture, you just say it's lymphoma from anyway. So lymphomas from thyroid does not, differ from the standard lymphomas arising from either, any other lymph node, for example. So it is exactly the same thing as you see here. So coming to the next investigative modality, which is the FDG PET CT, not routinely indicated. So kindly, all students, please don't say FDG PET is an investigative modality in thyroid at all. Okay, so that is the first important message you have to take. If you are asked what are the investigative modalities, FDG PET doesn't come in anywhere in picture. But why have I mentioned it here? I have mentioned it here because FDG PET is now being increasingly used for many malignancies. So if while they are doing FDG PET for some other indication, they pick up a thyroid nodule on the FDG PET, then you are supposed to evaluate them as you would evaluate any other nodule. So that is the only value for FDG PET, but it is otherwise not indicated either to diagnose or to follow up a thyroid nodule or a malignancy. Okay, is it clear to everybody? Is it clear?
Yes, sir.
Somebody answer.
Yes, sir.
Okay.
Yes, sir.
Okay, so because FDG PET is now being increasingly used for so many other malignancies or many other disease evaluation, they may pick up an incident. As I said, many of these thyroid nodules are picked up incidentally. And if it does pick up an incidental thyroid nodule, you then follow it up according to what the algorithm I'm going to come later to. You have to follow the algorithm. That's all. Okay, so FDG PET is only mentioned for that reason. So now let us come to how do we make decisions based on the so obviously clinical evaluation, as I told you. So history and examination is extremely important. We keep on stressing. See, the however many investigations have happened, have come into the fore, clinical evaluation still remains an extremely important cornerstone on which you make the diagnosis. So it is actually the role of clinical management, clinical investigation or clinical examination has changed in terms of, it used to be the only way of diagnosing somebody and then managing them. Then you got one of investigation, one after the other. So the role kept changing, but it still remains an extremely important role, in evaluating a patient. Then obviously you go to the radiological, cytological evaluation, and then you come to risk assessment. So you assess the risk of the patient in terms of his comorbidities and everything, and then decide on the right course of action. So now let us come to different scenarios. A thyroid nodule with a low TSH, which means the patient is hyperthyroid. So when the patient is hyperthyroid, as I said, the investigation of modality choice is radionuclide scan. So you do a radionuclide scan and then you see what the nodule is. You can either go for a solitary, if it is a solitary nodule, if the patient so wishes, you can do a hemithyroidectomy, including that nodule, or you can go for thyroid suppression and monitor the patient with a 6-month follow-up. Both of these options are clinically acceptable, and there is nobody will criticize you if you follow either of them. Then if there is failed suppression or the nodule progresses, then you can either go for a radioiodine ablation or a hemithyroidectomy. So as surgeons, you can boldly say, I will go for a hemithyroidectomy. But again, as I said, risk evaluation, if the patient is high risk in terms of surgery, then you can go for radioiodine ablation. Now coming to solitary nodule, which is in the either euthyroid or hypothyroid states. So the investigation modality is an ultrasound scan. A cystic lesion, you can do an aspiration cytology, and if the cytology is not suspicious and it is definitely benign, you follow up with a further follow-up scan at 6 months. If the cyst follows, fills up very rapidly, then you do a targeted FNAC and aspiration, and then look carefully if there is any suspicious cells. If it is a solid or mixed lesion, again ultrasound guided FNAC, and if it comes back as malignancy, obviously then surgery is the treatment of choice. If it is colloid goiter, you can follow it up depending on the size and other symptoms, pressure symptoms and things like that, or if it is a long-standing colloid goiter. Again, long-standing colloid goiter, multinodular goiters, there is potential for malignant transformation. So you need to be careful about them. So you can either offer surgery depending on if it is cosmetically not very, if the patient feels that it is cosmetically not very appealing, or if it is causing any pressure symptoms. Now, there are many, as you know, many things that, for risk assessment in thyroid nodules. So there are many sort of these aims, ages. So from the Leahy Clinic in Cleveland, they came up with this acronym AIMS, which is age at onset, metastasis, extent of the primary, and this one size of the tumor, which they made this algorithm based on the assessment of 821 patients. This you have to remember is the post-operative status. Again, from Mayo Clinic, you had what is called as the ages, which is age, grade of the tumor, extent of the primary, and size of the tumor. So these two have been shown to be of reasonably good, reliability in terms of assessing the severity and the prognosis of the patient. And the new one which has come again from Mayo Clinic is from double the number of patients, or more than double, which is called the MASIS, which is metastasis, age at onset, completeness of surgical resection, invasion, and size. So that comprises of the MASIS. So all of these things are there, but basically now I would say that all of these things have kind of been replaced by this, which is the AJCC 8th edition 2017. So this has actually encompassed most of the recommendations of all the previous AJCC classifications, and also taking into consideration the ages and AMS and the matches. So the TNM staging is now, I think, as sir said, TNM staging, is very difficult to remember. In terms of what you need to remember, probably the breast and thyroid, which are the two common malignancies in the surface, and maybe the soft tissue tumor, if at all you can remember them. Maybe these are the three tumors that you need to remember in terms of the TNM staging. So this is not that difficult. The T1 is less than 2 centimeters, limited to thyroid. The T1A is 1 centimeter, T1B is 1 to 2 centimeters. Not that difficult. T2 is 2 to 4 centimeters, again limited to thyroid. T3 is more than 4 centimeters, limited to thyroid, strap muscles. A is limited to thyroid and B limited to strap muscles. T4 again extrathyroidal extension, A to larynx and trachea and recurrent laryngeal nerve, and B to the carotid sheath, in terms of encasement. So T1 to T4, again A and B in T1 and T3 and T4. And the nodes, this is a new thing which is they've been included in the AJCC 8th edition, which is the level of the N1 is now 5 and 7. Okay, so 5 and 7 are considered as N1. N2 is again unilateral, bilateral, contralateral, level 1 to 4 and 8. Okay, so and M1 obviously is distant metastasis. So the AJCC 8th edition that came in 2017, I think it is quite a comprehensive, re-evaluation and review of the whole situation. What they have done is they have changed the age. That is, the age that is, sort of, what shall we say, which is, of a poor prognostic indicator. The age was initially 45, and this has now been changed to 55. Again, I think there is, in men it is considered 5 years, and in women it's considered 10 years. But I think that is again confusing. But this is the current recommendation. The age has been changed from 45 to 55. So this has resulted in 12% downstaging of the tumors. So what was considered as a high-grade tumor, because the age was 45, now because the age has now come up to 55, 12% of the tumors have been downstaged. Nodal involvement again impacts the prognosis, and this again has been shown that it impacts the prognosis again in patients above 55 years of age. And level 7, as I said, is now being classified as N1. And these changes have been validated by Morrison Allo et al. In BMC endocrine disorders. And this, they have done a retrospective review of significant number of patients by applying the new criteria to the old criteria on the same group of patients. And they showed that these changes that have happened in the AJCC 8th edition has actually been correct. They are correct to increase the age to 55, increase the nodal involvement to again above 55 years of age, and include level 7 as N1 node. And so these again, if you look at now, as sir said yesterday in his class about the pedagogy, and then the inclusion of artificial intelligence in our teaching methods. This is another EACCD. This is a new paper which is ensemble data for clustering of the cancer. So basically what they have done is they have applied artificial intelligence to the data from Mayo Clinic, the data from Leahy Clinic, and the data from all the the SEER data from American Cancer Association, and they have shown that tumor size, metastasis, lymph node involvement, age, and histology, grade, that is grade of the tumor. These are the 5 important factors which prognosticate the disease. So basically, I think the AJCC has to be complemented for comprehensively revising their recommendations, and I think that has been now borne out in 2 large studies. One is this EACCD, which is a artificial intelligence module using the data available from so many of the cancer registries, and they have actually shown, as I reiterate, that age has been changed from 45 to 55, and level 7 is now considered as node 1, and nodal involvement only impacts prognosis above 55 years of age. So coming to the objectives in treatment of thyroid malignancies, obviously it's a complete removal of the primary and involved nodes. Minimize treatment related to morbidity, that is, you avoid causing recurrent laryngeal nerve injury or hypoparathyroidism, hypocalcemia, and bleeding, of course, during in the initial part. Stage the disease accurately, facilitate post-operative radioiodine therapy, and minimize the risk of recurrence and metastasis. So this is the broad principles on which you manage. So coming to the algorithm. So I'll stop here. Ask for any questions or any clarifications you want.
Ravi, regarding Abdul's observation about FNA-C versus FNA-B.
Yes, sir.
Yeah, I agree that I don't think true cut biopsy, as we classically call FNA-B in the breast, for example. Yeah. I don't think true cut is used in thyroids. I agree with that. And I was just looking up some of the references and what they have called, for example, in this paper that I have put on the chat box, guys, you can download it and see what they have actually termed FNA-B, fine needle aspiration biopsy of the thyroid, is actually describing an FNA-C. It's just an ordinary needle that they have used for the cytology. So that is something that that I want the boys to focus on, so that perhaps I'm not very sure, but perhaps the 2 words are used interchangeably as far as the aspiration of the thyroid is concerned.
Yes, sir.
Yeah.
So Abdul, just to clarify, I think what sir said, basically you never use a true cut biopsy in thyroid. So, and again, the immunohistochemistry and flow cytometry come only if, for example, you see a parafollicular C cell, you're almost certain that it's medullary, and there is no medullary benign tumor. It's always medullary carcinoma. So if you see the parafollicular C cells and as an eosinophilic kind of stroma, the background, then you do the calcitonin, and then you'll get an answer, and then you can also follow that up with the same whatever specimen you have. You can subject that to immunohistochemistry and see if it gives you any more information. And same with lymphomas. So basically, I think those are the only 2 situations where you need immunohistochemistry. Others you don't need it. So I think that's okay. So now the flow, go to the history, and as I said, history. Yes.
Sir, one question. Sir, what they say is, if you are suspecting lymphoma, better to get a true cut.
Yeah, but
of the thyroid, because in FNAC you cannot distinguish that sample cannot tell you which type of lymphoma it is.
Yeah, you don't need that. See, as I said, you never get non-Hodgkin's lymphoma in thyroid. It's always NHL.
Okay.
So it's not such a big deal. I think ultimately, so I think it's not as
no, but Ravi, I think Abdul has a point that
definitely
we cannot say true cut is never done on a thyroid, but if you have, for example, a paucicellular aspirate, as in an anaplastic, you may have to carefully do a true cut biopsy. I'm not denying it, but from this paper I saw from the NCBI, the National Library of Medicine, They in thyroid, they describe a FNAB. They call it a fine needle aspiration biopsy, but the equipment described and everything is that for a cytology. That was the point I was trying to make. Yeah.
Absolutely. I think, Abdul, definitely, see, the take-home message should not be the outliers. So there is no
Yes,
doubt. So the outliers are very rare situations where you certainly, you want to get a diagnosis, you do it. Or if, for example, there is a thyroid nodule and then there is a lymph node in the neck, so you take the lymph node out. I think that will give you the answer. So no doubt, you may have to take resort to so true cut biopsy in those rare instances. But the take-home message should be that FNAC is the investigation of choice. That's all.
yes, sir. Yes,
Okay.
sir.
So history and physical examination, as I said, serum TSH is critical. Do the serum TSH first. Whenever they ask you in the exams, what is the first investigation? TSH. So if the TSH is low, radioisotope scan, hot nodule, either you can suppress the thyroid and see if it helps, or you can go for either surgery or iodine radioiodine ablation. If it is a normal TSH or a low TSH, either high TSH, then ultrasound scan, then 1 centimeter or more than 1 centimeter suspicious, you then go for an FNA and then deal with it accordingly as I outlined. And if it is a cyst, you just aspirate, and if there are cells which are malignant, then you have to treat obviously it as malignant and then deal with it as malignancy. If the cyst is benign, then follow it up. So this is the algorithm. So now I'll just go through the solitary nodule, the tumors, presenting it as as different carcinomas. This is not a class on thyroid malignancies. It's only approach to solitary nodule. So I will not go in detail about any of this, but just touch upon them. Okay. So the first one is papillary carcinoma. It consists of about 75 to 85% of all thyroid cancers, and it is the tumor associated with previous radiation history. Remember that very carefully. And then there is also 5 to 10% familial, the either RET, proto-oncogene, BRAF mutation, and all these things. And so the again, the malignancies which have increased the tall cell variant, and then these familial tumors have higher incidence of recurrence, extrathyroidal extension, and lymph node metastasis. So the familial papillary carcinomas are more aggressive and they metastasize to the lymph nodes early. So you have to remember that. And there is a female to male ratio of about 2.5 to 1. Again, this is a disease of the younger people. Follicular carcinoma is a disease of the older people. And so 30 to 50 years is the common age group. 70% of them are multicentric and 3 to 5% of them will show distant metastasis. So the treatment of choice, again, there is lot of discussion, there is, sometimes the, hemithyroidectomy makes a comeback, but the general principle is, because papillary carcinoma is a multicentric and multifocal disease, you are justified in saying total thyroidectomy, and in patients when there is nodal involvement, to do a central nodal dissection. So central nodal dissection in clinically or radiologically enlarged nodes with total thyroidectomy is considered as a treatment of choice. In patients with the N2 nodes, you do a modified radical neck dissection, and papillary microcarcinoma, if it is detected, you could then justify doing a hemithyroidectomy and follow up. The reason I say that is that if you look at the overall survival and disease-free survival, I think some of these terms may be confusing to you, but overall survival is the patient survives for whatever amount of years he survives, and also disease-free survival is survival without any trace of the particular disease that he's suffering from. So that is in common terms. So if you look at them, for a patient who has undergone a total thyroidectomy, let us say for a papillary microcarcinoma or a hemithyroidectomy, you follow them up for whatever 20, 30 years, and you look at their survival curves, they will be similar. So on that basis, they have justified only doing a hemithyroidectomy in papillary microcarcinoma, that is tumors less than 1 centimeter. Okay. Otherwise, the general current recommendation is total thyroidectomy. Then coming to follicular carcinoma, 10 to 20% of all thyroid cancers. Again, as I said, it's slightly more older age group, and female to male, this one is 3 to 1. And it is associated with iodine deficiency, but not radiation. And again, 10% of follicular carcinomas arise from previous multinodular goiters and patients with Hashimoto's thyroiditis and colloid goiters and like. The Hurtl cell variant again is much older age group and it has a poorer prognosis. 10 to 15% of follicular carcinomas present with distant metastasis. The prognosis is better in younger age group compared to the older age group, and it is less responsive to radioiodine therapy. These are some of the important features of follicular carcinoma. And as I said, FNAC is not useful. Capsular and vascular lymphatic invasion is the hallmark of follicular carcinoma. Again, the follicular carcinoma is divided into the capsular and vascular invasion being minimal and highly invasive. So again, with minimal, the prognosis is better compared to the highly invasive ones where you have a high incidence of distant metastasis. Less than 2 centimeters, hemithyroidectomy plus hysterectomy is one of the one of the recommendations. But the other problem with this is that if you do a hemithyroidectomy, then because follicular carcinomas metastasize by hematologic spread and there is potential for distant spread, with the thyroid, half of the thyroid being present, if you do a radionuclide scan later, you may not be able to pick up micrometastasis, which could then potentially influence the long-term survival. So hence, that the current thinking is that total thyroidectomy is the treatment of choice both for papillary and follicular carcinomas for two different reasons. For papillary, it is due to the multifocal origin, and for follicular, it is because of the possibility of distant metastasis. And only 5 to 10% of follicular carcinoma spread to the lymph nodes. The Hurtl cell variant is more aggressive, and the recommendation is total thyroidectomy and modified radical neck dissection as the metastasis rate is higher. So this is the example of the classical. You can see both the capsular and vascular invasion in this picture. Coming to medullary carcinoma, 80% of medullary carcinomas are sporadic, only 20% is familial. People keep on talking about MEN 2A and 2B, but it's only in 20% and hereditary medullary thyroid carcinomas. Again, a thyroid nodule which shows parafollicular C cells and raised calcitonin level is equivalent to medullary carcinoma thyroid. And the treatment of choice, please remember, is total thyroidectomy with central node dissection. If there are clinically or radiologically, usually you get a both, when you are looking at MTC, you have to do not only you have to do an ultrasound, you are well advised to do a CT or an MR scan of the neck to look for any presence of any nodal metastasis or extranodal disease, because sometimes that may not be obvious on either clinical or on ultrasound examination. So if you do that, if there are nodes positive, then you are definitely forced to do a bilateral modified radical neck dissection. So if there is no clinically palpable nodes or radiologically palpable nodes, then your treatment of choice is total thyroidectomy plus central nodal dissection. If nodes are positive, then you have to do a bilateral modified radical neck dissection. So this is the diagram showing the levels of lymph node. I think, as I said, 5 and 7 is now considered as N1. So anaplastic carcinoma, it comprises of only 1% of all thyroid cancer, fortunately, because it has a 100% mortality. It usually is seen in elderly patients, presents rapidly growing with pressure symptoms, may develop in pre-existing differentiated tumors, which is one of the reasons why you operate on patients with the long-standing thyroid nodules. And FNAC and CT scan will give you the diagnosis. Tracheostomy or hysterectomy may be the only surgical procedure you need to do to relieve the symptoms of respiratory difficulty. So in most of the time, you never do a total thyroidectomy in these patients. Occasionally, you may not have suspected anaplastic carcinoma. As sir said, if you get a poor cellular aspirate and you go ahead and if the patient is fit and do in a large goiter, if you do, sometimes you may do a thyroidectomy and later find out it's anaplastic carcinoma. But those are the instances where you do a thyroidectomy. Otherwise, most of them will be either a tracheostomy or an hysterectomy. Lymphomas may arise from multinodular goiters or Hashimoto's thyroiditis. When you see a rapid increase in size with systemic symptoms, diagnosis with FNAC and immunohistochemistry, flow cytometry, PET CT is definitely indicated in this to stage the lymphoma. As I said, it's either NHL B cell variant or maltoma. Chemotherapy is a treatment of choice. Surgery is only indicated if it is a malt lymphoma. You can do surgery and then also give them chemotherapy. Now, concentrating on the post-operative treatment. See, usually after you have done for either papillary or follicular carcinoma, you don't give thyroid replacement for up to 6 weeks to raise the TSH levels. They say it is definitely has to be upwards of 30 TSH. The reason for that is you make the either a residual disease or metastatic disease, iodine avid. You then do a iodine 123 scan if you have the facility, or a low dose I-131 scan to detect residual thyroid or distant metastasis. If there is any, then you go ahead and give the full blast I-131 radio iodine ablation. Then after that, you then do suppressive therapy with thyroxine. Usual dose is 150 to 200 micrograms, and that you keep the TSH in the range of 0.1 to 0.05. So that is the range you need to maintain your TSH levels. Thyroglobulin is again another, unlike in colorectal cancers where you need to have a pre-operative CEA levels and to monitor the post-operative CEA levels. In thyroglobulin is not, you don't have to do pre-operative thyroglobulin. Only post-operative thyroglobulin is indicated, and it is fairly good indicator of recurrent disease before clinical and radiological manifestations of recurrence happen. But again, it can be negative in about 10 to 12% of cases. So, but I think 90% is good enough. So the post-operative monitoring of these patients will include TSH and thyroglobulin. So that will tell you whether there is any evidence of recurrence. So TSH you do to ensure that your levels are kept, as I said, about that level 0.05 to 0.1 of the TSH. And then if there is any indication evidence, then you do a CT scan to detect recurrence either in the form of I-123, I-131. And obviously, if there are nodes and things, you can use CT and other things like that. So this is in essence an approach to a solitary nodule of the thyroid, whether it is benign or malignant. I hope I have not made anything very unclear or controversial. If there are any questions, I'll be happy to answer.
Very good and comprehensive presentations, Ravi. Congratulations. Any questions, please? Comments? I thought I saw Ramakrishna and there were Ramakrishna. You have any comments, please?
Sir, the heading was solitary nodule.
Yeah.
If you find two nodules, we still do the same algorithm or it goes for a different thing?
Sir, basically, solitary nodule, as I said, the definition has to be that it is the only nodule in relation to the rest of the gland. But if you find two nodules, you assess them independently depending on ultrasound scan to see if this nodule, the size of the nodule, as I said, a lot of these radiologic features. So the vascularity, the halo, and all these things, size and the shape, taller than wider and things like that. And then whether it's hypoechoic or hyperechoic, whether it is cystic or solid. So all of these features you take into consideration. If there are multiple nodules, the chances are that all of them will not be malignant. So you then evaluate the most suspicious of the nodule, and then, obviously, just like you treat the worst case scenario. For example, if any tumor, if the tumor, one particular area shows a poorly differentiated tumor, then you have to consider the whole tumor is poorly differentiated. So similarly, any thyroid nodule which is suspicious will have to be the one that has to be evaluated. It's very unlikely that a nodule that appears very benign on the radiology is going to become malignant, subsequently. It can, but it's very rare.
Yeah. Ramakrishna, the way I see your problem, go on, you're saying something, please go ahead.
No, if you find a clinically solitary nodule and ultrasound wise there are multiple nodules, then evaluation protocol, how it will be?
Yeah, you have to actually, as I said, you basically look at the ultrasound, look at the nodule that is most likely to be abnormal. Then you do the FNAC, ultrasound guided FNAC of that, and then follow the algorithm.
Yeah.
It's very unlikely that a nodule that appears very benign on the radiology will become malignant.
Sometimes we get, sir.
Go on, please go on. Yeah.
On ultrasound, the whole one lobe will be enlarged, not qualifying like a nodule. Even clinically also we find one whole lobe is enlarged. Then can you take it as just hyperplasia, or still it has to be evaluated as a nodule?
So basically,
Ravi, if I can take that question, because all these questions are answered by one basic philosophy. Why are we talking specially about a solitary nodule? That was with the question, say 15, 20 years ago when we first started focusing on solitary nodule. It was a belief that the malignancy in solitary nodule is much more than that in a multinodular goiter. That was a belief. And as you have rightly said, now the incidence of a neoplasm or a malignancy in either multinodular or solitary nodule is about the same, which is about 10 to 12%. Okay, so now what is important is two things. A, in the definition of solitary nodule is now based more on imaging than just clinical examination. So you must have a discrete nodule which looks separate from the parenchyma. So that answers your third question, Ramakrishna. It must be a discrete nodule which looks distinctly different from the parenchyma on ultrasound, on a good ultrasound. And so if it is a whole hyperplasia of a whole lobe, you would not consider it as a solitary nodule. And if you have more than one nodule, because the suspicion of malignancy is nearly the same as that of a solitary nodule, your approach would be that for the dominant nodule which is perhaps the biggest among the several nodules that you may see on the thyroid, you apply those imaging characteristics that were very well defined: microcalcification, taller than wider, margins, size. Size is a very important thing. So if you apply all those things, and if the dominant nodule is seen among the multinodular lesions on the thyroid, then you proceed with an FNAC and do the needful.
Sir, and the other problem is the specificity and sensitivity is not 100%, around 90% we can say.
Absolutely.
So even when FNAC says it is benign, how long can you wait? You said the 6 months. If it is malignant, does it cause harm to the patient?
Prognosis won't get affected that much.
So these are relatively indolent cancers. They don't really kill you. Thyroid cancers generally don't kill you. And so I think you can afford to wait. But there are two caveats to that. One, I think, is that the patient must be compliant with the thyroid suppression. You invariably, give them L-troxin to keep the TSH low. And B, they must be ready and willing and, able to come for regular follow.
Yes.
If these two are not possible, which can be in a substantial number of our population, I think you should go ahead and operate and make sure that you're not missing a neoplasm.
So at the end of 6 months, if nodule has not subsided, then surgery is required.
May not be. You have to again look at the nodule, whether it is cystic, solid, or mixed. Again, the same characteristics apply. So if it is cystic, you aspirate and see. If and again subjected to cytology. If it is solid, then again, obviously you have to look at all the characteristics and then again FNAC of the most suspicious area. And if there is any increase in size, obviously you will have to consider surgery.
There is an increase in size. There are risk factors. The algorithm that Ravi put forward are for the average population, but the risk factors are male, gender, size more than 4 centimeters. Some people consider it 3 centimeters. On the FNAC, the cytology characteristics, and increase in size on follow-up. If these things happen, better to take it out.
Even if FNAC says it is benign.
Yes.
Yes.
Again, FNAC is, I forgot to mention this, it is called the
Bethesda system.
System, and it goes from 1 to 6. So 1 is non-diagnostic, which is, as sir said, poor cellular aspirate, or they can't, there is a lot of blood or whatever, they can't say anything. You are advised to do the thing again. So that is considered 1, and 6 is considered malignant. So everything falls in between. Only difference will be 4 is considered follicular neoplasm. So 1 is acellular or non-conclusive, 6 is malignant, 4 is follicular neoplasm. So that is the Bethesda, sort of method of classification of the cytology.
Yeah. Okay. There is a thing in the chat box. Mekala says, could you please share the slides? I was going to say that. Please share your PPT. Yes, and sir. If you guys, you can download this. I have put up the perhaps the final word about FNAC and TrueCut, both in thyroid and parotid, and you will see that our conclusions, what we mentioned, were correct. Okay, you can. This is a 2018 article. You can download that, and you can also see the link that I put up in the chat box. That will give you more information about FNAB and FNAC. All right. I think it was a very, very nice discussion and class. Pooja, you will have the privilege of the concluding remarks.
Pooja, are you there?
Yes, sir, I'm here, sir. Just sharing the PPT to the group, sir.
Yeah.
I think it was a very interesting session, sir. Many of us have now, I think, have a clear idea on how to approach a thyroid swelling as per se. And
you see how it is difficult to give concluding remarks.
Yes, sir.
No. I'm pulling your leg, but
No,
yes,
sir.
I want you guys to get to know these things. How to chair a session, how to control and moderate a question and answer session. All this is a part of learning process. And so anyway, I wanted you to have a go at it. Go at it. Next time rehearse, you may get a chance again. But I will give the concluding remarks. I think we must congratulate Ravi on a very nice and interesting presentation, very comprehensive, very evidence-based. And this is the kind of lectures that I think give a lot of comprehensive information to the postgraduates. Some of them may find it a little confusing, but if you keep looking at these slides, go back and read the books again, you will have a consolidated view about a solitary thyroid nodule. I think the questions and answers were also very interesting. And I'm looking forward to more such faculty lectures, and I take this opportunity to request Ramakrishna to volunteer for some of the faculty lectures in this group. Thank you all for attending, and good night.
Good night, sir. Thank you.
Thank you, sir.
I will share my PPT in the group.
It's done. It's done
Yeah, okay.
on the thing. Yeah.
Okay, thank you.
Good. Okay.